Hello, good evening to everybody. Today we are going to do our last brain CNS session, and we will go at a high pace, should I say. We will be covering white matter neurodegenerative as well as white matter diseases, then congenital, then infections, and finally trauma. So if candidate one is with me, can you raise your hand?
Hi.
Okay, welcome. Can you tackle this case, please?
Yeah, sure. So these are selected MR images of the brain. So there's an abnormality centered in the thalami bilaterally. There's high flare signal, which is also high on T2, with corresponding low signal on T1. It doesn't demonstrate any hemorrhage on the SWI sequence. So differentials for this would include metabolic diseases, such as FAR, can also be due to toxicities and other conditions. Metabolic conditions like Wilson's disease can also cause this appearance.
Okay, fine. By the way, this is you called it a SWI? What?
Yeah, is it T2 style?
So this is a PD weighted sequence.
Okay.
And on a PD weighted sequence, please remember that the CSF is equal in signal intensity to the gray matter. So the vessels appear as a filling defect. And as I told you in the beginning also, PDs are out of fashion these days. But having said that, this is a PD weighted sequence. So PD, flare, and a T1. We'll just crack on with this differential because we had done this differential last time also. But the idea is here two different findings are there. First of all, there are abnormalities, bilateral symmetrical in the basal ganglia, which include, the globus, the putamen here, and the caudate, and then thalami. So two different findings are there. And in your book, there is a differential diagnosis. We did cover it last time also, but just wanted to show you a few more quick cases. Now, deep gray matter abnormalities. Look at this word, deep gray matter. So remember that basal ganglia is gray matter, thalamus is also gray matter. And but here, basically, what is meant is, in Chapman, what is meant here is basal ganglia. And you can see it can have vascular causes, and some of these are potential exam cases. Venous infarction is a very important exam case, which I have showed you previously. Global ischemia, or near drowning, etc., that can come in the exam. Neurodegenerative, forget about it for the 2B exam, luckily. Toxins are very important. So they will be non-specific findings, but carbon monoxide, methanol, cyanide. I've also seen it with what we call, antifreeze, and then metabolic disorders. So metabolic disorders can be inherited. Nobody is going to ask you all of this pediatric world in 2B exam. Wilson's disease should be in your mind. The case which I have shown you is Wilson's disease. So in another differential diagnosis in your book is bilateral thalamic lesions. So you will see that there is a bit of overlap between the two. But there are some conditions in which both of these findings are seen together. You see carbon monoxide can cause this. Internal cerebral venous infarct can cause it. So this is important for the exam. This is important for the exam. And Wilson's disease can also be like that. So this is, just give me the findings, please. Candidate 1.
Okay, so it's unenhanced CT head, and there is low attenuation change in the deep grey matter involving the thalami and basal ganglia. It's bilateral and has a symmetrical distribution. I can't see any associated mass effect or hemorrhage. So this would be in keeping with a deep grey matter abnormality, and again may represent ischemic or metabolic abnormalities or poisoning.
Right. And poisoning should be up there. This was another case where you can see thalamic as well as the basal ganglia abnormality. I've got quite a few in my collection. This is another one in which this is, if you see carefully, there is a bit of white matter changes also. This was methanol toxicity. This is again methanol toxicity on a CT scan. And this is carbon monoxide poisoning. You can see in this case, there is abnormality in the basal ganglia and restricted diffusion also on DWI sequence. So the idea here is it's not specific. You cannot be specific in the exam. You can just discuss the differential diagnosis. If thalamus is also involved, then you know that you have to go into this one and consider the ones which are given in your book in which both of them can go together, as I have pointed out. Okay, over to you. 20-year-old female.
Okay, so we have selected sagittal and axial images of the brain in T1 and flare. So there's abnormal foci of high flare signal around the septocallosal region of the brain and juxtacortical areas of the brain as well. They appear to be different sizes and different shapes. I can also see one in the right or bilaterally in the medulla oblongata on the image on the left. Having a look, there's also some subcortical white matter changes. So findings would be in keeping with a white matter disease such as multiple sclerosis. I would correlate with the history. I'd also look close at the eyes to see if there's any changes associated with optic neuritis and refer to the McDonald's criteria.
So, please continue.
And recommend post-contrast imaging to see if there's any enhancement of these lesions as well.
Okay, let me give you a hypothetical scenario. The optic nerves are normal in this case. On post-contrast, there is no enhancement. The patient has neurological symptoms, and this is the first presentation. What do you think is your diagnosis? What is your differential?
So I think my my first diagnosis would be multiple sclerosis, given the distribution, because I can see septocallosal changes, Dawson's finger, subcortical white matter changes. I'd like to know if there, without any previous imaging, we don't know if there's any new lesions, and we don't know if any of them are enhancing. To further characterize if they're lesions of different time and space. But I think my primary diagnosis would be MS for this patient.
And what is your differential?
I think I don't really have any for this distribution. It doesn't look like other white matter diseases like PRES or ADEM because of the distribution. ADEM. I don't have any other differentials for it in this pattern.
Okay, fine. Right now, we will come back to this. This is a differential diagnosis which is from previous edition of Chapman. So I'll build on this and we will go to the present edition then. So according to this differential diagnosis, the differential diagnosis of MS includes, vascular. So some of them are normal, mimicking MS, like age-related lesions. What is the, the relevant point, age-related lesions? Some people think that there is a formula, we call it 1 per decade. So if there are white matter abnormalities and these are in a 10-year-old 1, in a 20-year-old 2, in a 40-year-old 4, some people think they should be taken as normal. After the age of 60, they really, 30% of the people, they will have a lot of white matter abnormalities and we undercall them. And please also remember that MS is a disease of younger patients. It can happen in childhood also. And here comes the concept of small vessel ischemia. So small vessel ischemia can happen, it is age related, and that is why they are more frequently seen after the age of 60. But one entity which is very important for your exam as well as your clinical practice is vasculitis. Vasculitis is not mentioned in this differential, so I always tell my students to add it, vasculitis. And please remember that this is what happens if you are a neurologist and a patient comes to you with neurological features. Your differential will always be demyelination, vasculitis, vitamin B12 deficiency, etc. So they do a lot of screening also, and they will always do vasculitis screening. From the perspective of 2B exam, remember connective tissue disorders like SLE, in which the patient will be young and will have white matter abnormalities. So you should understand that what will be the difference between this patient and a patient of MS. Both will be young. Also, for your clinical practice particularly, and for your exam also, always remember migraine. It's not given in the differential, so add it in your mind. In migraine, what happens is that there will be quite usual subcortical, this will be subcortical, so that's different. Usually, subcortical white matter abnormalities. We will come back to the features of the plaques of demyelination in MS, but these are subcortical. So these two should always be in your mind. Otherwise, ADEM, which is acute disseminated encephalomyelitis, is in differential. Please remember the clinical difference between MS and ADEM is that MS is a multiphasic illness. Acute disseminated encephalomyelitis is a monophasic illness. Both of them can also involve the cord. But the lesions of ADEM are different than MS. So in the real world, you will always consider in your differential, part of the differential is clinical, which we will learn. But please remember that radiologically speaking, there are differences, and these differences will be asked in the exam. So I'll show you cases highlighting the differences. Now, central pontine myelinolysis. Remember this word, central pontine myelinolysis. Now the teaching is don't use this word. Use osmotic myelinolysis. Why? Basically, this condition can also involve structures which is other than pons. And sometimes pons might not be involved, by the way. That can also happen. So I'll show you a case, and this has come in the exam, osmotic myelinolysis. So this is from your previous book. Now, the latest book has divided white matter lesions into 3 headings or subheadings: punctate lesions, confluent white matter lesions up to 20 millimeter in size, and then diffuse white matter lesions. So the differential diagnosis changes. But one thing which I want to highlight from this differential diagnosis, look here, punctate lesions, and MS is there. But you will see that ADEM as an acute disseminated encephalomyelitis is not in this subheading. On the other hand, it is in this, under this heading. You will see it here. So what does it tell you? That in ADEM, the lesions will be slightly bigger, actually, more confluent. Sometimes, they are even like this, diffuse. But in MS, the lesions are more punctate. So, coming back to the case which was well described, we can see a few features which are quite classical. So you have to remember the classical features for MS. What are the classical features? Corpus callosum, particularly the undersurface of corpus callosum involvement. So if you see, this is the corpus callosum, and you can see, let me change my mouse to arrows. So this is the undersurface of corpus callosum, also known as callososeptal interface. So classically in MS, there is involvement of this. In some of the earlier studies, the sensitivity, specificity in MS for this was more than 90% actually. Now, Dawson fingers, if you look carefully, look at this one, look at this one, look at this one. These plaques oriented perpendicular to the corpus callosum. They are also beautifully seen on parasagittal sequences. So that is why, protocol-wise, in a patient of MS, we must do a sagittal flare sequence. And this is a potential viva question, because the examiners can ask you directly, or you can even say that I would like to see a sagittal sequence to see the corpus callosum. So undersurface of corpus callosum can be seen on a coronal also, but better seen here. And these Dawson fingers in parasagittal planes, better seen on parasagittal flare sequences. So basically the veins in this area are oriented perpendicular to the corpus callosum, and they say that MS is a perivenular disease. So these orientations are very important. Another fine touch is that you have to develop your vocabulary about white matter lesions and how will you describe them. So they can be periventricular when they are touching the ventricle. They can be in deep white matter here, and they can be in the subcortical white matter. So divide it like this. Another thing which is given in the literature, that the plaques of demyelination as in MS, they actually, at many of them, they can touch the ventricular surface. On the other hand, there might be a bit of 3 millimeter up to 3 millimeter distance of white matter abnormality of small vessel ischemia, for example. Now, other than this, this part of anatomy is the middle cerebral peduncle. So this is the pons, this is the cerebellum, and the connection between these two structures is known as middle cerebral peduncle. And some of the studies initially told us that there is high specificity if plaques are present here. This is the superior cerebral peduncle, which is the connection between the cerebellum and the medulla. And again, some of the studies have told us that there is high specificity if there are plaques there. At times you will see them on axial sequence also. So these are the features for which was correctly pointed out that this goes in favor of MS. So you should know that what are the features in favor and what are the features which are not in favor of other conditions which you want to discuss in differential diagnosis. So just a recap of the features. This is another case and just surface of corpus callosum. So even if there is not undersurface and involvement of the corpus callosum itself, just call it. Then superior cerebral peduncle. So here you are. This is the superior cerebral peduncle. Here you are. Here you are. Of course, this is the closoceptal interface. Now comes the role of contrast. It was correctly pointed out that contrast, I will use contrast to say, because I told you that hypothetically in the case which I showed you, there was no enhancement. But now there can be enhancement in active plaques of MS. Our criteria is there should be enhancement. Now, if there is enhancement, we call it active plaque of MS. And it can be, the enhancement can be complete ring enhancement. It can be what we call horseshoe enhancement, like this. Horseshoe enhancement is a very good feature which can discriminate a tumor versus MS, particularly tumefactive MS, which is an exam case I'll show you. And then there can be another enhancement which is known as nodular type enhancement. So there can be, if you see here, this is nodular. So nodular enhancement, ring enhancement, and horseshoe shape enhancement. Then comes the role of diffusion weighted sequence. Please remember that active plaques of MS can show restricted diffusion. And usually, initially, it will be bright on DWI and low on ADC map, but within 2-3 days, it might change. The ADC might become iso-intense to the parenchyma. Look here, DWI and central portion is low on ADC. And this comes a pitfall because I have seen people reporting and calling, because this is restricted diffusion, calling it a lacunar infarct. So you must know that active plaque of MS can also show restricted diffusion. Actually, some of the studies in literature, they actually told us that DWI should be routinely used. They suggested that DWI should be routinely used to pick up active plaques, but all of people do not agree with this. And in clinical practice, please remember, still our criteria is enhancement. It is not restriction. What I'm telling you now is key concept for your exam. How do you diagnose MS? And please remember the basics. If you are a neurologist, one of the basic things to remember is that MS is a multifocal, multiphasic illness. And so it will occur, if the symptoms, they occur again, only then can you diagnose MS. Classically in neurology, if a patient presents to you with neurology, you cannot diagnose that the patient has got multiple sclerosis. Time tells us. You send the patient back home. If the patient presents back after 6 months, 1 year, 10 years, then you say, okay, now this is the second phase, so I will label it as MS. So with that background, in the year 2000, a criteria was developed, and the neurologist who was heading this team his name was McDonald. So we call it the McDonald criteria. McDonald is no more with us now. So in 2005 and 2010, then this criteria was modified. And now we use the word International Panel or IP criteria. key thing to remember is that there have been changes in 2017, and this has placed MR more prominently in the role of diagnosis of MS. And this can be potential, questions for your in your FRCR exam. So the revised McDonald criteria of 2017 tells us, this is the key slide for you to remember, that when you diagnose MS, there should be the criteria of dissemination in space and dissemination in time should be met. And as far as dissemination in space is concerned, you should have T2 hyperintense lesions in at least two of the following, one or more than one. What are the two sites? So periventricular region, cortical. So I'll come back to this point, cortex. Juxtacortical means subcortical. Infratentorial means somewhere in the midbrain, in the brainstem or the cerebellum, and spinal cord. This is very interesting, cortical. So people don't realize that, it's a white matter disease, but please remember it also can involve the gray matter. So now involvement of cortex has been given, has been included in the criteria, and this only happened in 2017. So these are the 5 lesions. But this concept is an exam concept, dissemination in time. Please remember, multiphasic. Can we, on the first presentation, confirm using MR that it is a multiphasic illness? Yes is the answer. And what you can do is, you can give contrast to the patient. If some of the lesions they enhance and others do not enhance, what does it tell us? It tells us that the lesions which are enhancing are of different age, they are active. And the lesions which are not enhancing are older, so they are inactive. So this is the use of contrast. Another criteria, of course, is to do a follow-up scan in which a new T2 lesion, you will say that it is a new lesion. So, but using contrast, you can diagnose MS on the first presentation, and that is a potential viva scenario. So, candidate 1, this is your case. This patient, his first presentation, they were suspected about demyelination. Over to you. Let me tell you the sequence is flare, 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 DWI, DWI. I have not given you ADC, non-enhanced T1, non-enhanced T1, contrast enhanced T1, contrast enhanced, flare, flare. Yes, please.
Okay. So on the flare sequence, I can see periventricular foci of high signal bilaterally. I can also see more confluent areas on the third image on the top row, which demonstrate restricted diffusion. Having a look at the sagittal images, that does appear to have involvement of the septocallosal area. I'm trying to see if there's any
enhancement. Look at this, this, and this. Any enhancement?
I can't see any areas of definite enhancement, no.
Okay, maybe you cannot see it because it is very small image, right? Do you see this enhancement here? Do you see this thing?
Yeah.
So actually there is enhancement, and it is, do you see this enhancement?
Yeah.
So, and this was, some of these areas are also, so for example, if you tally this with this, there is a bit of restriction also. So the point is that can this be MS? Can you diagnose it as MS? Confirm it. First presentation.
I don't think there's enough information. We have got some periventricular lesions, but there isn't any, I can't see any cortical lesions or infratentorial lesions. And if we don't have any previous imaging for comparison, I think it wouldn't be enough to diagnose MS, so probably needs further imaging to evaluate and to see if there's any new matter changes.
Okay. We can diagnose this as MS. Let me repeat what I've told you. The point is that what is the definition? At least 2 of the following 5. You don't have to have lesions in all of them. At least 2 and the criteria is met. Periventricular is one criteria, just cortical is one criteria. And how many lesions? More than one, at least one or more than one. So in this particular case, you can see so many, you don't have to count them. They are definitely, some of them is periventricular. And then there are subcortical here. So the criteria is met. This criteria is met, dissemination in space. Then comes the criteria of dissemination in time. And look here, simultaneous presence of gadolinium enhancement and non-enhancing plaques at any one time. So that criteria is also met. Why it is met? Because this plaque here is enhancing. This plaque here is enhancing. Rest of the plaques are not enhancing. Telling you that this is, these are active plaques, rest of the ones are inactive. So please remember, MS is a clinical diagnosis. So they will tell you, we are worried about MS because of this symptom, that symptom. So you already know they are suspicious. And superadded to that, you get this kind of radiological features. And the bottom line is that by the revised 2017 criteria, you can diagnose it on the first scan, as in this case. Okay, thank you very much, candidate 1. We will go to candidate 2 now.
Hello.
Okay, you are with us. You can listen to me.
Yeah, I'm here now. Yeah.
Okay.
Sorry, I took a while the button didn't come up.
Don't worry. Don't worry. So look at the cord. Anything abnormal in the cord?
Yep, there's high signal at the level of C2 in the posterior aspect of the cord, and there's also lesions within the pons, so we could diagnose on dissemination in space.
Excellent. So this case of MS has got, and this can start. Please remember that 10% of patients of MS present with cord lesions, and it is taken as a bad prognostic sign. In the exam, when you see something in the spine, always look at the brain. And if brain is not provided, you tell the examiner, I want to look at the brain. They want you to say that. Remember this. In this particular case, there are lesions there. So already we have got 2 out of the 5 are there, right? Dissemination space. And then you can ask for contrast. You can ask for rest of the features to diagnose MS. Yes, please.
Okay, so you're presented with multiple MRI sequences of a 27-year-old female with weakness 2 months. There is hyper intense signal on flare and T2 that crosses the midline in the splenium of the corpus callosum. On DWI B1000, there is a horseshoe restriction, and that's genuine when mapped with the ADC. And on post-contrast enhancement series, this does show enhancement in horseshoe configuration. So this is consistent with an active kind of tumefactive MS.
Okay, so what is your differential?
Differential for this that's crossing the midline would be a high-grade glioblastoma multiforme. Could present like this.
27-year-old. Anything else in the differential in the tumor world?
Lymphoma, but wouldn't think that it would enhance like that.
No, lymphomas can enhance, and they should be in the differential.
Okay, cool.
The younger patient, maybe before the GBM. So absolutely spot on. Now, the point is that tumefactive MS is a type of MS presentation where there will be a large lesion and you will confuse it as a tumor. It can occur anywhere. But look at this case. In corpus callosum is involved. If you see there is a rim of restricted diffusion. And classically, they say that active inflammation is towards the white matter and towards the gray matter, which is this side. There will be less active inflammation. This DWI is quite impressive. This post-contrast is impressive, but not extremely, because a portion of this is also enhancing. Now, so this is tumefactive MS. Nobody can diagnose tumefactive MS just on the basis of a single image. You will consider things like lymphoma, etc. This is corpus callosum lesions in your book, and butterfly glioma and lymphoma are the top two. I have already shown you this case previously, and this is what we call lymphoma, periventricular. I've not given you all the images, but just wanted to make the point that it is crossing the midline, and it is actually multifocal, some rim enhancement, etc. is present. Yes, please. 2 years old, inability to walk 2 weeks after URTI. My history is too kind. The examiner is very kind to give you this elaborate history. So that's fine.
Okay, so my observations are that there is hyperintense flare signal within the deep white matter, relatively symmetrical in distribution, and it's also within the medial aspect of the cerebellum. There is no contrast enhancement in this context. In a young child that's got a URTI, I think this is likely to be ADEM. Right.
So, acute disseminated encephalomyelitis is a monophasic illness in which, as we discussed previously, the white matter abnormalities will be slightly larger or confluent as compared to punctate lesions, which are usually seen in MS. But MS can also present with larger lesions. One of the key exam point to remember is that other than white matter, at times, deep gray matter is also involved. So remember this. This is an exam point in ADEM. Not in each and every case, but sometimes it is. And this is what examiner is going to ask you. Look at the thalamus here. This is involved. Look at the basal ganglia, deep gray matter. Look at the dentate nucleus here, deep gray matter. So this, increases your confidence. Of course, this is a giveaway. Maybe the examiner will not tell you, or you might like to ask it. Please remember, in the real world, many of these patients, the history is too vague, and at times they just forget that they had something like this. Just to make a point that in ADEM, the lesions can be, larger. They can again show enhancement, which can be horseshoe shaped like this. Another case of ADEM in which one can have a debate here, that is it MS versus ADEM, and just on one study we might not be able to answer this question, but just wanted to show you restricted diffusion. Again, you will appreciate that the lesions are more confluent. Another one in which multiple lesions as well as cord lesions are, one can again have a debate here that this can be MS also. But in any case, let's crack on. Okay, now this patient is SLE, So you did a scan, and what are the findings? Is it MS, or you can explain it on some other grounds?
I don't think it's typical configuration or morphology with regards to the hyperintense signal, although it is predominantly periventricular. There's also basal ganglia involvement, and I wonder in the context of SLE whether this is a vasculitic picture, so more of a kind of small vessel disease, pathology, or vasculitis.
Vasculitis. So remember that SLE, connective tissue disorder or vascular. Connective tissue disorder is one cause of vasculitis, and there are many others. A neurologist will always do, screening for connective tissue disorders when a patient presents with MS-like symptoms. And if a patient has got vasculitis, this is the type of radiological features which you can get. There will be infarct of multiple ages. Many of them will be what we call lacunar infarcts. Lacunar infarcts are by definition infarcts involving small vessels. So the area will be between 5 millimeter and 15 millimeter. They will not be larger than that. Of course, there can be types of vasculitis in which large territory infarctions can also be seen. But if you see here, there is a lot happening, confluent high signal, there is a bit of gliosis, basal ganglia involvement, and then there are, at this internal capsule, this is acute, lacunar infarct. In the centrum semiovale here, again, acute infarct. So this is vasculitis. And as I told you previously, that vasculitis should always be considered in the differential diagnosis. But in the exam, you will, clinical presentation is important. But if the examiner tells you that this is the first presentation, you can go with the same debating point as we have already learned. This is not in your Chapman, this differential diagnosis, vasculitis. So I just wanted to highlight this, that vasculitis can be of various types, and bacterial, TB, mycotic, all of these things. But some of these you have to remember. Collagen vascular disease, you have to remember. In your clinical practice, always remember this, drug abuse, vasculitis. And we have seen so many cases now in our clinical practice of drug abuse, and particularly what we call recreational drugs, amphetamines, etc. People using them on weekends. We have seen so many patients, at times they will not tell you the history, they will hide it, and actually it was vasculitis. And otherwise you are going, is it MS, is it not MS, and things like that. So this should be up there. I don't think so for the exam, it's an important point, but for your clinical practice, always remember this. This is a case of migraine. And just to make a point, in migraine, high signal intensity foci are very, these are punctate. These are quite often seen. And the only thing to differentiate with MS is look at the distribution. These are subcortical usually, and they are not classical Dawson finger and all those things which we learn for MS. And this is small vessel ischemia. Now, small vessel ischemia after the age of 60 has got patterns which can depend. So if the patient has got diabetes, etc., or hypertension, you will have more confluent high signal. So the pattern is different. And age will be parameter there. And MS is always young age. There is an entity where old literature, which I'm going back to 1990s, and American literature particularly used to use this word senile onset MS. And you won't believe it that the word senile was used with MS, which occurs at the age of 50 or 50 plus. Now, nobody will use this word in this age. In UK, we know that till the age of 60, we use the word young. Between the age of 60 and 70, we use the word middle age. After the age of 70, it becomes old age. What I am telling you is very relevant for those of you who are logged in from overseas, because it's a cultural thing that this is how you tackle it in the exam also, that this is a young patient. So remember, till the age of 60, everybody is young. Yes, please.
Okay, so presented with multiple axial slices of a non-contrast enhanced CT head of a 50-year-old alcoholic with confusion. There is periaqueductal hypodensity.
So is this periaqueduct? What part of anatomy is this?
No, it's not periaqueductal. I apologise. That's in mid pons.
Pons, yes.
Yeah, it's in the pons. Apologies. And I can't, in the remainder of the slices, there's no global mass effect. I can't see any other hypodensity. I'm concerned that this could be central pontine myelinosis.
Excellent. So central pontine myelinolysis is an exam case. And please remember the concept that what was the classical teaching? Look at the word central pontine myelinolysis. We have this concept that if a patient has got low sodium hyponatremia and you treat this sodium, quite robustly or fast, there are some clinical rules. You should not treat it, more than this much millimole per 24 hours, which is irrelevant as a radiologist to know. But having said that, if you do it, then there can be demyelination, and this demyelination occurs in pons, and then you call it central pontine demyelination. By the way, it can be very severe or significant condition. There is mortality and morbidity. But later on, we came to know that it is not just sodium. It is not just correction of sodium. It can happen with other things like, blood, urea, nitrogen, hyperglycemia, things like that. If you treat it robustly or too vigorously, should I say. And the demyelination, it is not a must that it will occur in pons. Remember, it can basically occur anywhere. Where can it occur? It can occur in the cerebellum. It can occur in the white matter, in the thalamus, in the basal ganglia, anywhere, So some gray matter can also be involved in directly, deep gray matter. So now we use the word osmotic myelinolysis. And there is a pattern. There are 3 types of patterns now which are described in the books. In one pattern, only pons is involved. In second pattern, mix of pons and extrapontine demyelination. And interestingly, there is a third pattern in which pons actually is not involved. So remember that also. So you can have osmotic myelinolysis without involvement of pons. This is your case. And here is MR, which showed us the same changes, no enhancement. Yes, please, over to you.
Okay, so I've got multiple series of flare axial and DWI axial of a 47-year-old who is unconscious for 4 weeks. There is diffuse hyperintensity in the central white matter of the centrum semiovale, and symmetrical hyperintensity in the, are those the middle cerebral peduncles?
Excellent. So middle cerebral peduncles.
And they restrict on DWI on that focused area, and
so bright on DWI and still bright on ADC. But
okay, so that's T2 shine through.
question is more anatomy. So you have picked up this, and there is internal capsule. You see this internal capsule?
Yeah.
And this thing was actually this.
Oh.
So this patient presented with diabetic ketoacidosis, treated for glucose and electrolyte imbalance, and this is what happens. And just to make a point here, you can see that the pons itself, maybe the peduncle is involved, but the central pons is not involved. And to make a point that osmotic myelinolysis can happen without the involvement of classical middle pons. Can you see a CT scan on your screen?
Yeah.
So over to you. This patient, the history is 1 year and not well, fever and things like that.
So I've got axial slices through a 1-year-old's brain who's generally unwell with fever. They are contrast enhanced. There is generalized contrast enhancement, most notable in the frontal lobes bilaterally.
Describe this enhancement to me, where it is. I want to hear anatomy.
The enhancement follows the gyral surface, so I feel that this is more of a leptomeningeal enhancement rather than a pachymeningeal enhancement.
Excellent. So what is your conclusion?
So diffuse leptomeningeal enhancement. So, and in a patient that's got a fever and is unwell, infection as a cause of that.
Right. Okay, you can, and candidate 3 should raise the hand. Let me do a bit of teaching points on this case. Now, I am going to show you many cases of infections. We are going to go very fast. This is pattern recognition. Some of them are repetitions, so we'll go fast. But there are a few learning points here. This is a case of meningitis. And if you can see that there is enhancement of the surface of the brain, this is on the surface of the brain is what we call pia mater. So leptomeninges, as was, something which dips down the sulci, it has to be leptomeninges. But here is a space which is subarachnoid space. And if you look carefully, because we have given contrast, there is enhancement of the vessels, normal vessels. And when we give contrast, this is how you can differentiate that this is subarachnoid space and not subdural effusion, which can occur. On an MR, you don't have to give contrast, but on a CT, you can do this. So it's a good, tool to differentiate between subarachnoid space versus subdural space. If the vessel is going through it, means it is subarachnoid space. And you can see it on a CT scan if you give contrast. On an MR, or you can see it as a filling defect even without contrast, particularly with multi-planar sequences. Okay. Spot diagnosis.
Hello.
Yes, candidate 3. This is a, you can hear me, candidate 3?
Yes, I do.
Yeah, so this is a very easy case, but I just wanted to include it for completion. What is your diagnosis?
Herpes encephalitis.
Excellent. So if you see here in herpes encephalitis, what happens is that high signal, particularly the medial temporal lobe, or the what we call, this insula and subcortical subfrontal region, particularly this case is classical. All of you can diagnose it, so we'll crack on. Nothing difficult in this case. Again, very easy case, but what is this?
It's an extraaxial, mostly subdural abscess from the sinus.
Excellent. So, in head and neck, which we are going to start next week. Next week, I'm going to start with temporal bone. And in head and neck, I do teach a lot of anatomy because I know that head and neck is all about anatomy. So next week, this Thursday, we will start head and neck and mostly temporal bone. So in head and neck, infections are very important for your exam. Complications of head and neck, infections, particularly intracerebral and things like that. So this is an epidural or extradural empyema with the complication of sinusitis, and you can see it here also. Okay, this is a good case, so if you can describe it. Let me, for the audience, tell you the sequences. Here, flare, T1, T1 with contrast, T1 without contrast, T1 with contrast, and this is a cis sagittal. Cis is constructive interference in steady state. We have covered it when we covered the MR basics. So over to you.
Okay, so
I'm going to give you marks for your description.
okay, so the first thing that caught my eye is the basal meningeal enhancement surrounding the brain stem and in the interpeduncular cistern, as well as the ambient cistern. This is also appreciated on the sagittal post-contrast sequence. I can also see hydrocephalic, supratentorial hydrocephalic changes. I can see also high flare signal intensity bilateral symmetrical surrounding the frontal and occipital horns.
Excellent. Conclusion?
Conclusion is basal meningitis, maybe tuberculous meningitis, maybe pyogenic meningitis complicated by hydrocephalus.
So pyogenic, is it up there in your differential? So meningitis is fine, but etiology, my question is regarding etiology.
Yeah, mostly tuberculous or sarcoidosis, but given the fever, I'd be more inclined to bacterial meningitis or tuberculosis.
Yeah, please remember that TB can also have fever. Having said that, you have done very well. Let me take over. Now, the key points here is this is a very important case for the exam, and these kinds of cases have come in the exam so often. So please remember, I've given you all the sequences, etc. Everything becomes more easy to see. But having said that, if you just concentrate on this T1 weighted pre-contrast, I can open as an examiner this case and grill you on this case. So if you see here, this is the pituitary gland, this is the hypothalamus, this is the suprasellar cistern, and something is there. This something should not be there. So in TB, what happens is TB is basically a basal meningitis. So, the basal cisterns, they have got debris and granulomatous tissue there, which will enhance. And this also tells you that there is what we call extraventricular obstructive hydrocephalus. The Europeans use this word. We use the word in UK, communicating hydrocephalus. Basically, communicating hydrocephalus means that the obstruction is outside the ventricular system. Please remember that the CSF goes from the fourth ventricle into the basal cisterns, goes up into the convexity, and gets absorbed with the arachnoid villi into the sagittal sinuses. So the obstruction is at the level of the basal cistern. On the cis sequence, this should have been CSF. There is no CSF. On the cis sequence, I told you when we covered the first session, there are anterior and posterior recesses of the third ventricle. This is known as infundibular recess. This is the chiasmatic recess, and these are dilated. Then this is the pineal gland. This is the suprapineal recess. So all of these are dilated, and there is ependymal interstitial edema. Please remember, this is a Viva question. It has been asked in the Viva. How many types of edemas can be seen in the brain? So one is this one. This is known as transependymal interstitial edema. Then is vasogenic edema, which is white matter, and then is cytotoxic edema, which is usually seen in cortex, in stroke, etc. So this was, now in your book, there is a differential diagnosis of meningeal enhancement on CT and MR. We have covered it previously, But here we are seeing infections. Please remember the greatest mimicker, sarcoidosis, will always be there. So as far as infections are concerned, infections can be chronic infections, they can be pyogenic as in acute infections, and you have also seen a case of intracranial hypotension. Sarcoidosis will always be there. So dural enhancement can be done by these things, and leptomeningeal by infection, tumor, sarcoidosis are commons. So they will cause the same thing. This is, meningeal enhancement on CT and MR. And then is ependymal enhancement. So ependymal lining can also enhance, and that also is common sense that there might be infections there. This is from your old book, and one thing which I always used to teach here, this is from the previous edition of Chapman, enhancement of ependymal and subarachnoid space. So subarachnoid space, whole of the space, as in meningitis, I say that as if the river is on the fire. So what is the river? The river is, as in your case, the river was the supracellular cistern, and that supracellular cistern is replaced. There is no water there, no CSF. Instead, there is something else which is on fire. So this is river on fire sign for me. So TB, meningitis, of course, basically it is a route of entry is usually, through the CSF. So it is a basal meningitis. But there is a concept of hematogenous spread also. So the radiological features which can be seen include signs of basal meningitis. Look at this case. Once again, you can see this enhancement in the supracellular cistern. But with that, there can be enhancing lesions within the brain parenchyma. And they can be nodular enhancement. And once there is necrosis inside, there will be what we call ring enhancement. All of these things can go on. Please remember in the exam, many a times cases have come in which something is in the spine and something is in the brain, and the unifying diagnosis is that it is TB. So I'm just showing you a few examples of similar cases. This is on a CT scan, and you can see that there is enhancement here of the pia mater, and actually this is the same thing. And this was also TB, and this is a post contrast, and this is a flare which has got this high signal. And when you give contrast, it enhances. So nothing new on this case. This is multiple ring enhancing lesions. So there is a differential diagnosis of multiple ring enhancing lesions, which can be asked in the exam. It's an easy one. But just for completion's sake, this was TB, by the way. And this was all, necrosis, central necrosis. And in your book, there is multiple ring enhancing lesions, which can be neoplastic, which can be infections, which can be inflammatory, abscesses, septic emboli. These are important. Some of these we are going to cover shortly. Yes, please.
So these are coronal T1 post-contrast, as well as axial T1 post-contrast too. I can see, I don't have pre-contrast images, but I can see a left frontal enhancement, intra-axial. I can also see abnormally rounded enhancing lesion in the supracellular cistern. Maybe it's an aneurysm.
Okay, so I let me help you, because I can understand your handicap because you don't understand anatomy-wise where you are. This was the infundibulum, and this is a post-contrast. This is a post-contrast. This infundibulum is thickened and it is enhancing. This plus this, what comes to your mind? Can you describe the findings here?
Yes, there is patchy heterogeneous enhancement of the left frontal lobe.
Okay, so you have picked up enhancement here. What's happening here and here?
There is pachymeningeal enhancement posteriorly.
Okay, so with this infundibular enhancement, dural enhancement, some parenchymal enhancement, which goes to the edge, what comes to your mind?
Maybe sarcoidosis, maybe
Excellent.
TB,
Sarcoidosis.
also TB.
You see, in your book, there is a differential diagnosis of infundibular lesions, and we have covered it, right? Infundibular lesions, and there is quite specific things which can happen to the infundibulum. We'll come back to this point. Okay, different case. You are reporting this as on-call radiologist, and is there any stroke, particularly on right side?
Okay, so I can see bilateral frontal subcortical or deep white matter
And here.
there is pachymeningeal enhancement posteriorly.
Okay, so with this infundibular enhancement, dural enhancement, some parenchymal enhancement, which goes to the edge, what comes to specific things which can happen to the infundibulum? We'll come back to this point. Okay, different case. You are reporting this as on-call radiologist, and is there any stroke, particularly on right side?
Okay, so I can see bilateral frontal subcortical or deep white matter hypodensity.
Yeah, that is age related. I'm not interested. Any?
Okay, I can see what might appear to be, other than the lacunar, the obvious lacunar infarct, what might appear to be like an left MCA, hyperdense MCA sign.
Excellent. So you have picked up a lacunar infarction here. This is what you said?
Yes.
Can it be anything else?
Could be Verkauer space.
Verkauer space, very good. How will you differentiate between the two?
Diffusion and flare.
Say again.
fusion weighted images and FLAIR by MRI.
By MRI. Okay, very good. So let's go back. By the way, I am going to come back to that case, which was sarcoidosis case, which you picked up, you know, that infundibulum case. But first of all, let's develop our concepts. And these concepts are about perivascular spaces. By the way, there is a differential diagnosis in your book, which is enhancing lesions in perivascular space. This is the first time in Chapman this has been included. And neurosarcoidosis is there. Neurosarcoidosis is the greatest mimicker in neuroradiology. So, Virchow-Robin space, or what we call perivascular spaces are seen again in this case here. So this was the CT scan. This was not a lacunar infarct. This is a Virchow-Robin space. And the learning point is that what are these spaces, and what is the significance, particularly vis-a-vis our exam. And so I've just realized that I think I have overshot for the break. So what I will do is, let me stop here, because there's a bit of teaching involved here. And I'll mute myself. We'll come back after 5 minutes. So it's a 5-minute break. Right. So we were candidate 3. Can you listen to me? Can you hear me? No, maybe we have to unmute you. So where is candidate?
Yes,
Yeah.
I can hear you.
You can. Okay. So we were doing some concepts of Virchow-Robin spaces. So the point is that see here, this is the subarachnoid space. So this is the arachnoid, this is the pia. The vessel goes through the CSF, goes into the brain. Now, if you see the microscopic view here, this is the artery, and then this number 3 is what we call the Virchow-Robin space, perivascular space. Perivascular space is different. Don't confuse it with, the sub. So this is the brain parenchyma. This is the subpial space. This is the perivascular space. So these are the lenticulostriate arteries. These are exam arteries. I will tell you quite a few pathologies. If you know the anatomy, they will you can make out. Now, and particularly one of them is Cryptococcus, which I'll show you a case shortly. So these go through this, from this M1 segment, it go into the basal ganglia, taking in this Virchow-Robin spaces. Spaces are, look at this picture here. So Virchow-Robin spaces at times can be dilated or prominent. Variant. And they are, so in the basal ganglia region, many a times they will be dilated, and don't confuse it with a lacunar infarct. Similarly, they can be along the convexity, the medullary arteries, which go into the sulci. So this one here, this one, this one. And third one, which is described in literature, is in the midbrain. So if you look at this MR carefully, you can see this. Look at this pattern. All of these are Virchow-Robin spaces. This one is a Virchow-Robin space. Here, in the region of the basal ganglia, this is a Virchow-Robin space, and these are not what we call lacunar infarcts. Other examples. Look at this one. So many multiple and this one and this one. So I've seen it so commonly that people confuse it and they just report it as a lacunar infarct. Sometimes what happens is that in this example, it shows you that when you give contrast, sometimes it is not in each and every case. You can see actually a vessel going in the middle of this cystic space. So this is another evidence that this is Virchow-Robin space. Now, why is this important for us, Virchow-Robin spaces? Because some of the inflammation or infections, they go into the parenchyma through them. And when they go into the parenchyma, they will appear as if they are parenchymal. Of course, they are now parenchymal, but the pattern actually is an evidence of how did they proceeded into the parenchyma. Now, sarcoidosis is known to occur like this. It goes through the Virchow-Robin spaces into the brain parenchyma. So if you see here, there was infundibular lesion, the unifying diagnosis, meningeal enhancement. This one, of course, it is intraparenchymal, but if you look carefully, it goes all the way to the cortex, indirectly telling you the connection. This is another case when we reported it in our hospital. This was a young patient, 23-year-old female. Initially, we reported it as a primary tumor or solitary metastasis. There was so much edema, and there was some enhancement. Initially, it was picked up on a CT scan. If you look carefully, this enhancement goes all the way to the edge. Of course, nobody just on this can say that this is sarcoidosis. I'm not showing you a CT chest, abdomen, and pelvis of this patient, which had classical signs of sarcoidosis. But having sarcoidosis as the greatest mimicker. And then the unifying diagnosis, you know, the differential diagnosis of infundibular lesions with this is Rico-Robin spaces. Okay, over to you. What is happening here?
So there is massive dilated supraventricular system with periventricular calcification, I think, as well as calcifications in the right eye, maybe bilateral ocular calcification. I think this is a congenital CMV infection.
So I lost your last sentence. Can you repeat that, please?
I think this is in keeping with congenital CMV infection.
Excellent. So this is one of the stigmata of what we call torch infections, which include toxoplasmosis, others, rubella. CMV is the most common herpes simplex. Key exam finding is that there will be, you know, these are infections which pass through the into the fetus through the placenta. Now, the key finding is that most of these will have subependymal, what we call calcifications. And they will show you in the exam neonate with intrauterine, skull calcifications on a plain film. It used to come so often in the past. They can also show you a CT scan. Basic concept is that this is not hydrocephalus. This is parenchymal destruction. But there can be so many patterns. The key things to remember is that CMV is the most common, and subependymal calcification, various kinds of parenchymal changes, which can happen in white matter, gray matter, cysts, destruction of the parenchyma, etc. All of these things is a spectrum. This patient reported to A&E, young African female. She was very disoriented. CT scan was sort of normal. Did this MR. This is a flare sequence. This is a T2-weighted sequence. There is no enhancement on the post-contrast. But how can you explain this finding? She is young.
Okay, so I can see bilateral, fairly symmetrical, confluent IT2 and flare signal in both deep white on the deep white matter on both sides. It does not involve the subcortical U fibers. On the sagittal, I cannot see anything else on the sagittal or coronal views. So in conclusion, this is a white matter disease. It does not fit press, or also does not fit demyelination, or maybe a severe form of demyelination or severe form of vasculitis, but I'm more inclined towards white matter diseases like PML and HIV, leukoencephalopathy.
Excellent. Okay, well done. Now, candidate 3, thank you very much. Well done. And candidate 4, raise your hand, but I'll do a bit of teaching on this case. Now, this is from your old book, HIV and the brain. HIV is very important for the exam, and it can come as a long case. And I have put in screenshots from your current edition just to highlight that this is very well, you know, there is a summary in the second part of the book, acquired immune deficiency, and both in children as well as in adults. So you can read it from Chapman, actually. Now, this differential also tells you what kind of things you should remember in HIV. There is infection and tumor. As far as infection is concerned, there can be HIV encephalitis. There can be CMV encephalitis. Both of them, the point to remember is that they will have what we call dirty white matter. You know, this is dirty white matter. So whole of the white matter has got this kind of confluent finding. PML is very important because in PML, we will come back to PML shortly. So I'll tell you about PML on a film. Secondary infections like Cryptococcus is an exam case. It has got a unique finding, which we will learn. Toxoplasmosis and TB, you know, ring enhancing lesions. Ring enhancing lesions, we have seen, you know, other stigmata of TB. Lymphoma you have done. So all of these things you have to remember. The case which I have showed you is, you know, either HIV encephalitis or CMV encephalitis, dirty white matter. So we have to see the cases of PML and we have to see the case of Cryptococcus. So,
hi.
Okay, welcome candidate 4. So, this patient is known case of HIV. There is neurological deterioration. They are worried. How will you tackle this? This thing. Please remember that there is no enhancement. I am, because of time factor, I am going fast. So I'm sort of telling you a few things in a leading fashion. Over to you.
Sure. So there are multifocal patchy confluence signal alterations, mainly involving the white matter. Most marked in the left cerebral hemisphere. I'm just trying to track out to see whether the subcortical white matter is involved in this case. I can see that some area that is involving the subcortical white matter as well. And given the patient's history, so I'm thinking of deciding between the PML or HIV encephalopathy, because it's an asymmetric appearance. So I will, and involving the subcortical white matter, so this will favor PML.
Excellent. So let's go back to the basics of PML. So just a recap, please remember PML. This is PML, progressive multifocal leukoencephalopathy. What is PML? PML is an infection, and this is a JC virus. Please remember that in 80% of normal brains, this virus lives there. But in an immunocompromised patient, it takes over, it attacks the oligodendrocytes and causes demyelination. Now, this demyelination, the classical pattern which you have to, you know, the books tells you that usually parietal and occipital lobe, but now people have realized that this pattern is, you know, quite atypical. It is not symmetrical. So that was very well tackled, that it is not symmetrical. Please remember, cytomegalovirus and HIV, they will be more symmetrical dirty white matter changes. Another thing which is critical, subcortical U fibers, U as in the alphabet U. So these are known as subcortical U fibers. Involvement of subcortical, you see this one here, which is, look at this U shape, subcortical U fibers. Involvement of subcortical U fibers is one of the pathognomic signs of PML, and it will not enhance. Please remember, in the Viva, they will show you and you will ask, I want to do enhancement. Because if it enhances, your differential changes, goes into lymphoma, goes into all those infections, you know, toxoplasmosis and TB, etc. PML will not enhance. So previously, PML used to be diagnosed, you know, usually they have got these are HIV patients and the CD4 is very low, maybe between 50 and 100. But they used to diagnose it with a biopsy, but now, or since many years, biopsy is not needed because you can do CSF analysis as well as MR and you treat it. And prognosis has also become quite good with, you know, heart therapy, etc. But the latest concept which I want you to remember is that don't go home with this idea that PML can only occur with AIDS. There is, look at this list. and suppressive therapy. There are drugs which we use for MS in which patient can develop secondary PML, and the clinician will ask you if there are signs of PML. And look at this, such a long list. And so PML can occur with all of these conditions. This is another case of PML. Just wanted to highlight the subcortical U fibers once again. Look at this subcortical U fiber. Look at this subcortical U fiber, this U, here, here. So, and no enhancement once again. Yes, please.
Sure. So this is a series of MRI brain of a 32-year-old patient with known AIDS. So I can see there is signal alteration centered in the deep gray matter within bilateral basal ganglia. So I'm thinking down the road of infective causes for this with affinity in the basal ganglia includes toxoplasmosis. I'm looking for the post-contrast images in below, which shows enhancement of this rounded lesion, so which further reinforce my initial interpretation.
Hint, anatomy. My hint is anatomy. Anything comes to your mind?
Sure. And so it is. So I can see the lentiform nucleus is involved on the right side, and also the internal capsule.
Bilaterally.
Yeah.
Bilateral symmetrical type of finding.
Yes.
Anything comes to your mind? No. Okay, let me take over. This is a classical case of cryptococcus. So please remember, cryptococcus is one of the fungal infections which can occur with AIDS. You see this thing? Fungal cryptococcus. Cryptococcus becomes an exam case. Why? Because of radiology, it has got unique radiology. What happens is that cryptococcus actually sorry, let me. So cryptococcus, it produces mucoid material, and it goes through the the lenticulostriate arteries into the perivascular spaces. This is what we learned, perivascular spaces into the basal ganglia region. And it will give you cystic type of appearance on T2 weighted sequences, for example, bilateral symmetrical. So it has gone into the lenticulostriate perivascular region, and then it has, because it has produced mucoid material which is high signal. At times it will show a bit of enhancement, and there will be other cases in which the enhancement will not be very significant. Look at this one. And it's a very unique finding, bilateral symmetrical. So once you know this, then you can make, it's an Aunt Minnie type of a case. Aunt Minnie means in AIDS, if you find it, Aunt Minnie is a case in which there is no differential because of this pattern of infection, extension. So of course, when you see ring enhancing lesion, toxoplasmosis, TB, both of them will be there. Now, tumor versus abscess. In the exam, I can show you this case, I can show you this case, and your differential will be that it is an abscess or it is a necrotic tumor. Please remember, a necrotic tumor will means it's a high-grade tumor. Now, on a CT scan with enhancement, one of the parameters which you have to describe to the examiner is, we say that if the enhancement pattern, the wall is smooth, uniform, more likely to be abscess, but if it is nodular and irregular, more likely to be a tumor like this. Having said that, there is so much overlap that we are not very good. So the king sequence for the exam is a DWI sequence. Over to you, candidate 4. what is this? Is this an abscess or is this a tumor?
So I'm focusing at the bottom slide, which are the DWI sequence, and it shows restricted diffusion, which is in keeping with the abscess.
And which part is the restriction? So this part, which part is the restriction?
The
is it in the wall,
restriction
or is it in the lumen of the lesion?
is at the nodular wall of the lesion. So it could mean that it's a highly packed nodular wall cells of a tumor.
Sorry. So what is your conclusion? Is it a
So
tumor?
I changed mine.
Yeah. So you were right first. Initially you were right.
Right.
And please remember that this has been asked in the exam so many times. So many times. Where is the restriction? If you look carefully, it is in the central portion, which correlates with this portion. And the wall does not show restriction. This is low signal on DWI. And so the portion which is because of pus. And that is how you differentiate between a tumor versus an abscess. This abscess is quite unique because in the wall there is a bit of hemorrhage, and hemorrhagic abscesses can happen, but that was not my teaching point. The main point was here. What is happening here?
So again, looking at the DWI images, I can, on top there, we have peripheral enhancing lesion. And on the DWI images, there is restricted diffusion in keeping with the abscess.
And where is it going?
And it's going into the ventricle, causing ventriculitis.
So please remember that this type of scenario has been shown in the exam many a times. Now the examiner will show you this type of a scan. If you see here, subtle finding, this is low signal, but this is slightly different signal. And you are struggling if there is a level there. And the king sequence here is the DWI, which shows that within the ventricle, abscesses, pus is sitting there. Actually, there was a parenchymal abscess and this, and you can also see ependymal lining, which is enhancing. So the idea was to show you ventriculitis, ependymal enhancement. Yes, please.
So 30-year-old male, acute headache and confusions. I can, on the CT, there are multiple foci of abnormality in the right parietal and also in the midbrain. And on MRI, it shows post-contrast enhancement. And I'm just looking at the pre-contrast.
This one did not show enhancement. I have not given you on MR. And this thing shows enhancement.
Yeah.
What is your conclusion?
So I'm thinking this is a Neurocysticercosis.
And why do you say that? Convince me. And you are right, by the way.
Because the history is Mexican, so I'm going down the road.
So the examiner is very, what we call kind, isn't it?
Yeah. So I mean, there's different stages of the neurocysticercosis.
So what is this stage? You convince me. What is this stage and what is this stage? Tell me more.
So on the top one, without enhancement, and there's areal calcification. So it is I believe that's vascular.
This is not calcification. This was not calcification. Let me correct you. So then how do you explain this?
So we have a hyperdense central with peripheral low density.
So what is this stage? And what is this stage?
It's, the first one is a colloid. I'm not entirely sure, sorry.
Okay, good. At least you remember the word, so I like that. And this is the colloid. So let me come back to this. Now, this is from your book. And again, I am a strict believer in the word, I call it book memory. I think read cysticercosis from your Chapman. The second part tells you lesions can be seen in subarachnoid space. Concept 1, brain parenchyma. 2, ventricles. And you can make cases out of cases from cysticercosis. So many cases can come in the exam, but if you know the principles, you can make out the radiology, you can make up the radiology, otherwise you will be struggling. There are 4 stages: vesicular space, colloid stage, granular, and calcified. So let me explain to you. Basically, before I explain to you, for your interest, cysticercosis is endemic. It is the most widely distributed parasite in the world. So this is Tinea solium. And pig is intermediate host. And human beings can become intermediate hosts, orophycal route or drinking it and things like that. Eggs, I mean to say. Now, Central America, Mexico, many countries of Africa, as well as East Asia, as well as East Europe. So huge distribution. Most interesting thing is that in the area of distribution, this is the most common cause of epilepsy. So this is the clinical scenario, and this can be asked in the exam. The examiner might show you this patient presented with epilepsy, and you will not know the connection. So, the most common cause of epilepsy in the endemic area is cysticercosis. And what happens is this colloidal stage. Basically, what happens when it goes into the brain, it just sits there. The larva, so the central portion here is the central portion here is the scolex or the larva. This, by the way, is viable. It is alive and it can grow, and surrounding it is a cyst. And it will stay there. They have documented cases of it sits there for up to 30 years, and average time is about 4. Point something years, 4 point. Then what happens? It can inflammatory reaction, and this reaction becomes symptomatic. This is the colloidal stage becomes symptomatic, and the patient will present to you clinically and when you give contrast, there will be enhancement, ring enhancement. There can be what we call leptomeningeal enhancement or dural enhancement, and so it will be very acute. Then inflammation, it's slightly, it becomes, it settles down, granular nodular pattern, and finally nodular calcified stage, which will be like this. Calcified stage anywhere will have calcification. So these are vesicular. Look at this, nodule within a cyst, nodule within a cyst, cyst with a nodule. If I ask you in the exam, you will be worried that this is a cystic space. This nodule is the key finding for the exam. This is the vesicular state. Colloidal, always, give contrast and it will enhance. Now enhancement is very minimal in this granular. So nobody is going to ask you this stage. Of course, calcified can be asked because of calcification. So examiner can simply show you this thing on a SWI sequence, and you will be saying, oh, is this micro hemorrhages? And actually it will be micro, small calcifications. Few differential diagnoses, just to make my point, which neurocysticercosis is in the list in your Chapman. One of them is intracranial cyst with a mural nodule. This is in your new Chapman. And if you see neoplastic and infection, so there is a cyst with a mural nodule, and the only thing is neurocysticercosis, just like this case, this nodule, it's a key finding. So only infection which can cause this. Tumors, pilocytic astrocytoma, etc. It can cause hydrocephalus, of course, because it is in the ventricles. It can present as abscess. It can present as calcification. It can also cause meningeal enhancement. So many things it can show you. Okay, candidate 4, last case for you.
So this is a 35-year-old male with headache and a series of MR which shows a rounded, well-defined cystic lesions in the right hemisphere, and there is minimal perilesional edema. So this, I'm thinking this
Any enhancement? Any enhancement?
and there's no enhancement on post-contrast images. So this is most in keeping with proencephalic cyst.
Porencephalic cyst. So porencephalic cyst is a cyst in which there is basically a previous brain insult, such as infarction, surgery or trauma, etc. There was nothing like this in this case.
Okay.
Basically, this is the differential diagnosis of intraparenchymal cyst. So your thinking is right, but I'm not satisfied because I knew the clinical history. So over to you.
So given the patient has got headache, I'm thinking this lesion is related to the symptoms.
Okay, let me give you a hint. You are doing the chapter of infections.
Okay, hydatid.
Hydatid. You see, hydatid has got unique features. In hydatid cyst of the brain, only about 1 to 2% of cases end up having hydatid of the brain. You can have various kinds of radiology, and there is, according to the type of hydatid has got, various types of hydatid will have slightly different radiology. Please remember the classical daughter cyst, etc. can also hydatid. If you go back to the histology, has got 3 layers, and if the layer becomes crumbled inside, you will get those membranes. There can be daughter cyst also, just like you can have daughter cyst in the liver or the lung. But classical hydatid, which will come in the exam, is like this. In this hydatid, there will be no, one of the features which is very impressive is that there is no edema and there will be no enhancement. Please do not go with this idea that all hydatid will not enhance, but there are types of hydatid which do not enhance. So, so this is one of the features because you can differentiate it. There will be other types of hydatid in which there will be enhancement and you will be less confident. So this was hydatid. Okay, thank you very much. We go to candidate 5. We are cracking on to the next. Candidate 5, are you with us? Let me check. Yes, you are. Can you hear me? Maybe not. Let me see. Okay.
Hello, hi.
Okay. So this is congenital. I am going to show you about, I think, 6-7 cases from congenital, and I want to crack on very fast. And so these are the cases which have come in the exam, and then we will go for trauma. You will like trauma because all of you know trauma. So we'll go very high speed. Okay, candidate 5, over to you. And please remember all of these cases which I am showing you have come in the exam.
Yep. So these are 3 representative axial images of a CT scan in an 8-year-old child, non-contrast study. I think the most obvious abnormality is the presence of a nodular appearance of the lateral aspects of the ventricles, which have got the same attenuation as the gray matter. I think this is possibly in keeping with heterotopia.
Excellent. Use the words which, subependymal heterotopia.
Yeah, subependymal. Yeah.
Okay, let me take over. Very well done. But please remember in the exam what will happen. This is the last site you are going to see and you are going to panic. Up and down, you are going up and down and you are not going to pick up. And this is a classical case where, as I say, the eye see what the mind knows. You have to train your mind, look at this region. And this is subependymal heterotopia. So the concept is that subependymal heterotopia on a CT scan or CT, and you can see these nodules, bilateral nodules. And on each sequence, which will be T1, candidate 5, can you hear me?
Yeah, it's going on and off actually, sorry.
Yeah, there was a notice on my, Zoom that my internet connection is playing up. I am in hospital, so this is the official connection. I hope it is working now. Can you hear me now?
Yeah, it's fine now actually. It was just very sporadic a bit earlier, but I can hear you now.
Sure. Okay. So if you see here, the key thing here is that it will be equal in signal intensity to the gray matter on all sequences. This is flare, this is T1, this is T2, this is PD. And similarly on CT scan, but you can understand that this will be a very difficult case in the exam scenario to pick up. You will panic before you pick it up. So this should be one of your review areas. Now, heterotopia, please remember the concept that the germinal matrix in a developing fetus is in the periventricular region. The gray, gray matter cells, they actually develop there, and from there they get transported or they migrate laterally. They can be arrested if they can be arrested a mass, and you will be worried what it is. When you do an MR, you see the signal intensity is equal to other. And subcortical heterotopia is usually also involved with very prominent veins. So these filling defects are veins. It is known to occur like this. Third type of heterotopia. So this is a sort of a coronal of the same patient. And you can see that actually it goes all the way and touches the ventricle also here. Third type is this type, which is known as band heterotopia, and in which the gray matter cells, this is bilateral symmetrical, so it becomes more difficult, this particular example. But you can see that there is white matter, then there is gray matter. And then there is white matter as band. I've seen this come in the exam, but anybody can show you. Band might be more difficult, but you should know this. Dandy-Walker spectrum, I am going to leave it. You know all of this. It has come in the exam quite a few times. Recent years, no. I think it's a very easy case. You know that there is a Dandy-Walker malformation and there is a Dandy-Walker spectrum. And Dandy-Walker malformation, of course, there is a cyst in the posterior fossa with Vermean degeneration, which connects with the fourth ventricle. It might be associated with hydrocephalus, corpus callosum. In this case, there is hydrocephalus shown, but look at this complete agenesis or dysgenesis of corpus callosum. The confluence of sinuses is moved. So I will skip it. It's too easy. Okay, yes, candidate 5.
Okay. So these are axial.
Because of my factor, let me help you. Look at the foramen magnum.
Foramen magnum, okay. So in this 38-year-old patient's MRI brain, concentrating on the posterior fossa, I think there's some crowding of the foramen magnum, especially in the bottom left and bottom center image. I can't see much CSF spaces, much CSF.
So what is happening here? What is your impression here? You have picked up the finding very well.
The cord looks a bit abnormal in that image.
So if you see cord is here, something is sitting behind. If you look carefully in the next one, there is no CSF, and some anteriorly is the cord and something is sitting behind. So now here, yes, please.
Sorry, I thought it was I'm just wondering if there's increased intracranial pressure and causing some herniation of the tonsils of the cerebellum.
Okay, so the patient hasn't got but something else. You have got the diagnosis.
Yeah, so it's a Chiari malformation.
Excellent. So this is carry one malformation. Please remember, they will show you on an axial slice. And you have to develop your eyes to pick this up. Now, the learning points in carry one malformation is that I have seen it being overcalled so many times in our reports. Basically, the criteria is that the tonsils should not be more than, if they are more than 5 millimeter, you know, if you draw a line here in your brain, below this portion of the bone. But having said that, the fine touch is that they say don't overcall it. Call it when it has got a pointed edge. If it has got a circular edge, then don't call it. If it has got a pointed edge like this peg shape, we call it peg shape, or the folia are oriented vertical, then you call it. Please remember that carry one malformation can be very symptomatic. In 50% of cases, people overcall it at times, but having said that, they forget that it can be very symptomatic. Even patient can have, MS-like symptoms and things like that. So it's an important clinical diagnosis at times too, and people at times do surgeries, etc. Basic concept is that the posterior fossa has got less space than it should be. So you have to pick it up on an axial slice.
Okay.
Yes, please.
So these are sequential axial CT hit slices of a 29-year-old patient. The apparent abnormality is the presence of CSF fluid within the cleft in the left parietal region. This is in keeping with a scissioncephaly, I think. So it's a close-lipped.
Excellent. Okay. So scissioncephaly or scissioncephaly, whatever you want to call it, can be closed lip and open lip. Basic thing is that this is closed lip and this is open lip. Basically, basic thing is that it is lined by, so there is a cleft, it is lined by the gray matter, and this gray matter is critical because a porencephalic cyst, as we just discussed a while ago, that porencephalic cyst is a cyst because of cortical or parenchymal destruction secondary to old brain insult, like an infarct, like a tumor or surgery, etc., radiotherapy, etc. So that will not be lined by gray matter. So this lining by gray matter is critical. And so even here, you can see that there is gray matter at the edge. And this is closed lip. This is bilateral open lip. And this is porencephaly, which goes all the way to the ventricle, but it is not lined by the gray matter. And obviously, in the definition, you have to remember that it goes from the CSF of the cortex to the ventricle. So this is a type of case, this is what I call about FRCR exam, that the bar is going up and up and up. And I believe that this was a bit harsh to be shown in the exam, but it has been shown in the exam. And that's why I'm showing you. And I have given you some lead points there because of the time factor. 2 years, poor vision, endocrine dysfunction. Over to you. What is it? Look at the poor vision apparatus on this scan.
Yeah. So these are several MRI slices, mostly coronal and a single axial. I'm looking for any of it. I mean, given there's poor vision and endocrine dysfunction, I'm looking for any abnormalities in the suprasellar cistern or possibly in the optic tract or the radiation.
So do you think that these optic nerves
so there's a central area of low signal in keeping with a single monoventricle. So I think this is septo-optic dysplasia.
Okay. So this is septo-optic dysplasia, but what is happening here?
Could there be an element of scissioncephaly there as well?
Yes. So it can be associated. So what happens now? As I told you that this septo-optic dysplasia has come in the exam. In this condition, what happens is that the optic nerves are, dysplastic. They are small, thin. Optic chiasma will also be thin, so the patient cannot see. And 80% of them will have endocrine disorders. So pituitary radiologically might be normal, might not be normal, but endocrine dysfunction is there. Another key finding is absence of the septum there, and it can be associated with schizencephaly. So this has come in the exam. Yes, please.
Okay, these are several axial MRI slices of a 6-month-old child. No history has been given. The ventricles appear to have a slightly odd configuration. I'm wondering if the thalami are slightly abnormal. And in the second row, third image, there's a
hint. You have picked up the ventricles. Look at these two ventricles.
Yep. So I was wondering, yeah, this is a racing car configuration. And the specific term just escapes me now. Sorry, it's a racing car configuration abnormality. And I just can't remember the name of the pathology.
What is your diagnosis?
I can't remember the name, sorry.
Okay. This is corpus callosum agenesis. Basically, when there is corpus callosum agenesis, what happens is that the lateral ventricles at these levels, they are widely spaced and they are parallel to each other. Now, if you see a coronal, but no examiner is going to show you a coronal, they will always show it on an axial. If this gives you that whiting head or moose head appearance. So this is corpus callosum, which is absent, and these are known as proboscis fibers. These are longitudinally oriented white matter that just go in. So there is, upward displacement of the third ventricle, and this is that moose head or Viking head appearance, which you can also see here, but nobody is going to show you. You have to develop your eyes or an axial slice. Nobody is going to show you a sagittal, but you can ask a sagittal once you pick up on an axial. And if you see here, these were parallel. With that, please remember that there is a concept of colpocephaly or colpocephaly where the occipital horns, this is because of orientation of white matter tracts adjacent to it. They also appear dilated. So this is the same spectrum. So there is, the third ventricle has moved superiorly. So this is corpus callosum agenesis. And what do you think is happening here?
So 22-year-old female with bifrontal headaches. So there's low attenuation within the corpus callosum. I think this might be fat density, so it could be a lipoma of the corpus callosum at the frontal and the genome.
So the corpus callosum is there or not there?
So agenesis together with a lipoma present there.
Right. If you see here, the same, this and this parallel, and these are widely placed because of this. You will ask the examiner that I want to do Hounsfield unit. With that, there is bracket calcification. So at this side, there is calcification of the corpus callosum with a lipoma. At other places, lipoma will not have calcification. Lipoma is a choristoma or a hematoma in the intracranial cavity. So if you see here, look at this. And if I show you the MR, you can see that the lipoma is sitting there. So this is lipoma of the corpus callosum. screen, on your
Yeah.
screen. Okay, this is just a teaching case, so I don't want you to, I don't want to bother you. And you see, this is the type of case which, if I have got an examiner, I will like to show you. Because this is a 73-year-old with a corpus callosum agenesis, complete agenesis. And the point is that I will open an axial slice and you will go up and down with, say that there is atrophy, this is small vessel ischemia, blah, 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 blah. But actually what is happening? Look at the ventricles and they are, look at the space and they are widely spaced. They are parallel. That's the key. You come back, come down, the third ventricle has gone up. And look at this colpocephaly, which can happen in corpus callosum agenesis. And this is 73-year-old. And if you see the MR, there was a bit of, I should use the word dysgenesis, because part, anteriorly atrophic, but it is there. So, but the main thing to learn is that they will show you in an axial slice in the exam, axial CT or an axial MR. Okay, now we crack on. You are going to enjoy this, all of you, because you report a lot of trauma. So it's going to be, just many cases, but we will go very fast. And the Viva things and things like that, I think I have got it other way around. Yeah. So candidate 6, can you now see my screen changing hematoma density?
Yeah.
Okay. So this is a teaching slide. Basically what, in trauma, we will go very fast. But the idea is to show you many things. And most of this stuff, you know it. But in the exam, what happens is they might show you subtle things and things like that, which you might not pick up. So this is what I use the word develop your eyes and your thinking that what can be asked in the exam. So one concept is that on a CT, hemorrhage, it loses density about 1.5 Hounsfield unit. And so this is a day 16 hematoma, and the density is now 45 Hounsfield unit. Initially, it was 65. Please remember that acute hematoma on CT scan is between 56 and 76 Hounsfield unit. So this is very basic, and I'm not going to go further into it. I'm not going to teach you hemorrhage on MR because we have done it. And in the CT, in the trauma world, usually it is CT, except for diffuse axonal injury, in which you might like to use SWI sequence, and we will see a few cases. Okay, just my question is a lead question. How will you tackle this? How will you describe it? Can I hear your description, please?
Yeah, there is
trauma.
So it's an axial CT slice non-contrast with areas of hyperdensity in the right parietal region with surrounding edema and cervical effacement. There's also effacement of the lateral ventricles on the right side with some midline shift towards the left. So these are in keeping with intraparenchymal hematomas or hemorrhage with the edema around it and signs of pressure effect on the ventricular system with midline shift. I would like to scroll through the rest of the image. I would also like to see the bone window as well. Just
so what is your conclusion? What is your diagnosis? Just in one word or two words.
So it's an intraventricular hematoma and intraparenchymal hematoma. There's also a suggestion of some isodense subdural as well on the right side.
That is just an artifact. So you are calling it an intraparenchymal hematoma, correct?
Yeah.
Okay, so that is the point. Don't use this word. The point is you have to be very, this concept here, primary head injury can be divided into primary, secondary, and delayed effects. Primary is at the time of injury. There are only two types of parenchymal injuries which can happen. One is contusion, and second is diffuse axonal injury. With that, there can be hemorrhages, as in extradural, subdural, subarachnoid. There can be fractures also. So this is a contusion, and contusion, by definition, think like a bruise. Bruise is when the surface, if you are hit, you are playing cricket and you are hit on your elbow by a cricket ball, you'll get a bruise there. So on the skin surface. So the surface of the skin is the cortex. When the cortex hits the skull, usually there are particular sites, for example, base of skull, etc., frontal lobes, because undulated appearance of the skull base is there. So contusion will occur there. So by definition, part of the cortex has to be involved. Now, contusions can be two types. One is non-hemorrhagic, which is low density, and then is hemorrhagic, and which is, of course, punctate, high density will be there. So if you see here, this is what is happening, but if you see carefully, it goes all the way to the cortex. So call it a contusion. Look at these secondary effects. Cerebral edema and ischemia, this is asked in the exam, and I'll come back to this. Herniations are important. Embolic complications, including arterial dissection, this is important. And long-term effects, particularly, let's say, leptomeningeal cyst, this has come in the exam. I've also shown you arteriovenous fistula, dural AV fistulas before. This and this I'm not going to show you. Leptomeningeal cyst I have shown you, but maybe we will just revise it. I will come to this concept, and I will also come to this concept. Diffuse axonal injury is very, very important. So what is happening here in the frontal lobes? Just give me the diagnosis.
So there are bilateral frontal lobe contusions.
Excellent. So this is the type of contusion where you can imagine that it has, the gyri, they have hit the base of the skull. Then there is low density, and then there is punctate high density. So this is contusion. Now, please remember the concept in trauma world. All of the lesions, may it be contusion, may it be diffuse axonal injury, may it be extradural, subdural, it can enlarge. It can enlarge. It can become bigger. So, as a radiologist, key thing to remember is that if you are on call and somebody has asked for a scan at 2 o'clock and you report this scan, you say that there is contusion. 6 o'clock in the morning, the patient has deteriorated neurologically speaking, and the clinician wants a rescan, don't refuse it, do it, because things might have changed. So, so remember this concept. This patient, after 12 hours, this was the subcortical contusion, subfrontal, and then it has become such large parenchymal hematoma goes into the ventricle. Please also remember that this case has come in the exam, or similar case, quite a few times. They will show you subtle frontal contusions because of anatomy, because it is just next to the base of skull. There might be artifacts there. It might be a subtle finding, and you are going to miss it.
Yeah, there is.
On this is different, and this is different. So, what is there something in the subarachnoid space on this scan?
There is a locule of gas on the,
How will you confirm this?
I would do a bone window, and then we'll check for the fracture for pneumocephaly.
My question is more basic than that. So you are absolutely right. You will go for bone window. You will go for an associated fracture. If you see here, there is a hypodensity. What is this hypodensity?
It's most likely air.
How can you confirm this? Okay, what is this hypodensity?
It's again most likely air, but it could be again fat can have the same kind of appearance. We'll have to go through.
Excellent, excellent. So this is a ruptured dermoid, by the way, which is an exam case, and this is pneumocephalus. And the key thing is that you have to ask for what?
Hounsfield unit.
Excellent. So ask for Hounsfield unit, and this will happen in the exam. That even if you pick up here, you will say that I would like to confirm it. Of course, when there is history of trauma, it is more likely. What about a patient having a dermoid and a ruptured dermoid with secondary trauma? That can also happen. So this skill I am trying to emphasize, ask for Hounsfield unit, ask for Hen. This was ruptured dermoid. Fat will have anywhere density between about -50 to -100. This will be minus few hundreds like 600, 700. Pneumocephalus, I'm just showing you, all of you know what is pneumocephalus. Pneumocephalus sometimes can cause pressure effects also. This case, if you see here, there is a lot of base of skull fractures, and there is so much air that it is causing a bit of pressure effects here. And look at the word tension pneumocephalus. You have seen tension pneumothorax, but this is the pneumocephalus. Okay, a bit of anatomy, and this anatomy is a recap. All of you, who are sitting the exam for you, all of you know this, but just a recap. That what points vis-a-vis the exam of anatomy, which will be very helpful. Now, this is the lateral ventricle. The lateral ventricle has the frontal horn, body, and the trigone. This is the temporal horn, and this is the occipital horn. Please remember that the trigone is quite a substantial structure in a craniocaudal dimension. So if the slice is going like this, this is the level of the body. So posterior to the body is going to be the trigone. Look here, frontal horn, body, and trigone. On the other hand, if the slice is going here, so this is the third ventricle, this is the occipital horn, again trigone is there. So look here, this is the third ventricle, trigone is here. Occipital horn is here. Now, usually occipital horns are not well seen unless patient is advanced age, as in slightly atrophic type of brain. But they have shown cases in the exam where what has happened, because occipital horn is dependent. The patient is lying down and there might be intraventricular hemorrhage sitting in the occipital horn. And the question is, where is this hemorrhage? And that's a very well-defined hemorrhage. And the answer is, this is in the occipital horn, instead of saying that this is in the parenchyma. So this was about this. Now, coming back to the anatomy, we know that from the lateral ventricle, it goes through the foramen of Monro into the third ventricle, and then to the, the aqueduct and the fourth ventricle. Now, anatomy-wise, few things for the trauma world are important. Look at this. This is the level of pons, and this is the level of midbrain. And pons has got this belly. I call it the fat man. And this is the midbrain, which is the Mickey Mouse. So this appears like a Mickey Mouse. Now here, this is the cerebellopontine angle cistern here, and this one. This cistern is important for you vis-a-vis herniation. You will see when there is transtentorial herniation, one of the things which will happen is that the cerebellopontine angle cistern on the ipsilateral side will become widened as compared to the contralateral side. So you have to, when you, in the exam, there can be marks for the description, because the examiner have to discriminate between somebody who will get 6 marks and pass, somebody who will get 6.5 or 7 or 8 marks. So descriptions are important. They are seeing what you are picking up. Now, just superior to this level is a very important level vis-a-vis trauma or whatever. This is the suprasellar cistern. So this is the pons. This is the posterior clinoid process, anterior clinoid process. Just superior to that, I am just superior to the level of the pituitary fossa. Here, there is pons. Interpeduncular cistern. Interpeduncular cistern is an exam cistern. They will show you subarachnoid hemorrhage sitting here. Around this, anatomy is very critical. This is the ambient cistern. This is the quadrigeminal plate cistern. This thing is the uncus. What is uncus? Uncus is the medial most portion of the temporal lobe. And this is the structure which, dips into the incisura, into the hiatus to cause transtentorial herniation. When it slips inside, it will compress this and this will be projected, displaced to the contralateral side. On the other hand, it is going to encroach on this cistern, which is this cistern. This is the suprasellar cistern. So when there is transtentorial herniation, initially suprasellar cistern is going to be partially effaced. And then when there is blatant, full-blown transtentorial herniation, the suprasellar cistern is going to completely vanish. So these are important, anatomy features for trauma. Now, look here, intraparenchymal hematoma, intraparenchymal, and it has gone into the occipital horns. This is the trigone. It has gone into the occipital horn here. 3 different patients, occipital horn. This one is in the ventricles, but this is at the level of trigone. This is the body. Okay, candidate 6, trauma. What are your findings?
I can see there is high density within the subarachnoid spaces on the left cerebrum towards the vertex in the second last axial slice and the last one as well. There's also some contusion in the inferior frontal, left inferior frontal lobe.
Excellent. Well done. So the idea here was to pick up 2 different findings. And so there is a subtle contusion. And this one is a traumatic subarachnoid hemorrhage. Please remember that trauma is the most common cause of subarachnoid hemorrhage. And so this is 2 things which have, and the bottom line is that in the exam, always go till the vertex. So subarachnoid hemorrhage here might be just on one slice higher in the vertex. Look here, subarachnoid hemorrhage in the interpedunclar cistern. Look here in the interpedunclar cistern. Any subarachnoid hemorrhage?
Just going through. There is some high density, especially on the right side, parietal occipital junction.
So this is the Sylvian fissure, right?
Yeah, there, but on the first slide as well, I think there's a bit of high density in the subarachnoid space.
Okay, fine. So basically, subarachnoid hemorrhage in the Sylvian fissure. Okay. The history of trauma in this case was about 4 days old. Is there some finding?
Yeah, there is some. Sorry, I just quickly go through.
Go to the vertex, please.
There is some subarachnoid hemorrhage on the left cerebral hemisphere towards the vertex. In the last.
Can you be sure that this is subarachnoid hemorrhage? Can it be anything else other than subarachnoid?
Yeah, there could be calcification in the gyral calcification, gyral fold
calcification. Look at the density.
It's not that high. Yeah, you're right.
Calcification will always be more than 80 Hounsfield unit. You see, if you see this, this is something like the gray matter.
It looks more like to me hemorrhage to me, more like.
What else can it be? How are you going to tackle it in the exam? That's the basic question.
In exam, look at other sequences as well, and also.
Nothing else except for this finding, this finding, this finding, this finding. Now, if you look carefully, this is, if you see this.
There's some sulcal effacement I can see here as well.
Absolutely. So there is sulcal effacement. Look at the sulcus. That sulcus is not visible here. That sulcus, there is something sitting inside, and there is all the way up. So look here versus here. Look here versus here. So there is effacement of the sulci, and there is some high density. You cannot be sure that this is subarachnoid because the density is not 56 or something, right? So. Yeah. What can it be? How are you going to tackle it? That's my question.
Do an MRI?
First thing, so what is your differential diagnosis for this finding? MR is a bad answer, but what is your differential diagnosis? Because I'm going to ask you the same question in MR also.
Yeah, it could be some kind of tumor as well, or some mets, some.
Okay, now if you see here, this is a revision from your first basic session. This is 6 days old subarachnoid hemorrhage, which was not at all visible at that stage in the CT scan. Here on the MR, what happens is that it is bright signal within the sulci. Similarly, on the CT, what is happening? That there is some bright signal, bright density, slightly high density, but you cannot make out that this is hemorrhage. Bottom line is that when you see this finding, it can have a differential diagnosis. The differential diagnosis can be a leptomeningeal process, as in infection, carcinomatosis, can also be subarachnoid hemorrhage. So the answer is that you have to give contrast. On a CT scan, if you want to ask for MR, fine, not a bad answer. But even on MR, ultimately, if you pick it up, you have to give contrast. And when you give contrast, then you can discriminate between the two. You know, subarachnoid hemorrhage versus leptomeningeal process. And this is a flare sequence with a high signal, and on enhancement, it enhances. And this is esophageal carcinomatosis. So these cases I have shown you previously. Okay, just very basic case. What is happening here? And I want to hear the words. What is this?
So on the left, on the left side there's extradural, acute extradural hemorrhage. On the right side there's a contusion, and there's also subarachnoid hemorrhage as well.
Excellent. So subarachnoid hemorrhage can be, traumatic subarachnoid hemorrhage. That was fine. Is there a extradural hematoma on this case?
On the left side, there is some air density.
Temporal, middle cranial fossa. Is there something happening there?
Yeah, there is some anterior to the midbrain. There is some low density. No, that's
okay. You see, this extradural hematoma, which is middle cranial fossa, has come in the exam quite a few times. It's a difficult one, and that is why I'm showing you an example. If you see here, there is, and in the exam, it's easy to miss because there will be a bit of hemorrhage. Intentionally, I had not shown you this one here because it's visible, and then it is visible here on a coronal, it is visible here. Middle cranial fossa extradural hematoma is easy to miss and has come in the exam quite a few times. How are you going to tackle this or this case if you are reporting this? Classical viva question.
Yeah, in the patient one, there's a
this
large.
Is the same thing I am showing you.
Okay.
I'm showing you patient 1 and patient 2 with the same finding. My question is a viva question. You have picked it up. You are the on-call radiologist.
Yeah.
What is happening? What will you do?
I can see the blood of, extradural hematoma, but then there are different density blood within it. So there could be an acute bleed within the previous extradural hematoma.
Excellent. Previous extradural hematoma.
Not previous, I mean to say acute on acute or acute on subacute kind of stuff,
Acute and acute is a better way. But okay, I'll come back to this. What will you do? This is a Viva question.
We'll do an angiogram here as well to see.
Okay, this is a critical thing to pick up. You see, the point is that you are an on-call radiologist. You pick up this extradural hematoma. Within an extradural hematoma, if you see, this is known as a World sign. If you see this low density, means that there is active bleed going on. This is how you infer it. It's not, don't confuse it with the subdural hematoma. And means active bleed means that the patient is bleeding when the patient is on the scanner. Means you don't know what will happen 10 minutes, 20 minutes down the road. What will you do? You will pick up the phone. Excellent. You will pick up the phone and tell the surgeons this is what is happening, and urgent management. So extradural hematomas can also enlarge, like this case here. So at 2 o'clock, it is very, very small, and then it has expanded. Yes, please. A&E, history of trauma.
So there is an acute or rather subacute kind of extradural hematoma on the right inferior frontal lobe.
Extradural hematomas are not subacute. Extradural hematomas will always be acute.
Yeah, the density looked slightly less to me than my liking, so that's what I was thinking. But
that's a very good thinking. And look at this slice. Anything comes to your mind?
There is some calcification at the periphery of it as well.
How do you explain that?
It's an old collection with some infection, or maybe some.
What do you think this is?
The calcification shows there's a chronic process. So.
Excuse me, have you noticed that I've shown you the next
meningiomas, maybe elliptical kind of meningioma?
This is a meningioma.
Yeah,
that was a trick case.
Yeah.
It's a trick case which can come in the exam.
Yeah.
You see, this is a classical trick case where you assume things. And by the way, this is what happened in this case. This presented with, history of trauma. And the key thing is that this is a meningioma with calcifications. You start thinking, why calcification? Give contrast. And this is a meningioma. Okay?
Yeah.
This is your last case, and candidate 7 should be ready then.
So there is an acute subdural hematoma in the left occipital, in the region of left posterior fossa, abutting left cerebellar peduncle. There's also some pneumocephalus there as well. I can see the subcutaneous air locules as well. In the bone window, there is a fracture through the bone as well. So a fracture, pneumocephalus, and subdural.
What kind of hematoma is this?
I think it's no. It's I will have to reconsider because it's by lens of it. Again, it's extradural hematoma, I would say. But I would scroll through. I think it looks like a.
Explain that. How can it happen? Etiology.
Trauma?
Anatomy. No, extradural hematomas. Extradural hematoma. What is
normally it's the meningeal artery.
So what has happened here?
Shear force. This skull looks a bit deformed.
Okay, I'll take over. You can mute yourself. Thank you. Well done. Now, this is a very, very good exam case, and this is what we call a extradural hematoma, which is the etiology is it's a venous extradural hematoma. Please go back to the basics. Extradural hematomas can be arterial and venous. Usually 80 to 85% of them are, or 85 to 90% are because of medial meningeal artery rupture. But when a venous sinus is ruptured, it can cause a venous extradural hematoma. Anatomy tells you this is posterior fossa, and what the structure here is the transverse sinus. And one of the key findings here, and that is why it becomes a very, very important exam case, very good exam case, is this. This is the jugular foramen. In the jugular foramen, you can see a bubble of air. And what does it tell you? That once there was a fracture, the dural sinus tear was there, and air has gone in, and part of the air is sitting in the jugular bulb also. So this is a venous extradural hematoma. Okay, candidate 7. What is this?
It's a subdural parafalcine, posterior parafalcine subdural hematoma.
Excellent. So subdural hematomas, so favorite for the exam, subtle subdurals, and you have to understand what will happen. Subdural hematomas, they cannot cross the midline, they go along the falx, they can go along the tentorium. Now, this portion for the exam is very important because a subdural hematoma will go along the tentorium, and this is the hiatus. So the midbrain is sitting here, and it might go here, it might go along this. On an axial slice, it will become difficult to pick up. And this is what they show in the exam. So if you see here, this is dura, this is the inner lining of dura, this is the falx. And a subdural hematoma will go like this. This MR beautifully shows you what happens, that it is going along the tentorium like this, along and over the convexity, but it cannot cross the midline. So this is the MR of the same case. Now this is the type of case which comes in the exam where we can see this hematoma, and the question is, where is this hematoma? And people confuse it. You know, somebody will say it is in the occipital lobe, somebody will say it is in the cerebellum on an axial slice. But the key is that part of it is going along the dura. And you see, this is what I'm talking about. And this means that it is within the tentorium. So this has come in the exam so many times. Where is it? That is, they're going to grill you on an axial slice. Look at this case, and it goes along the dura here, along it, and this is an MR which tells you where it is sitting. It is sitting in the tentorium. It is sitting in the tentorium. But on an axial slide, it becomes a bit confusing. Okay. History of trauma. Is there a
There is a small subdural hematoma along the right parietal region, just at the region of the sylvian fissure.
slice? Whereas slice top row below, second row?
So I can see it better sort of in the middle image, in the first and middle image in the bottom row.
Okay. What can you do to confirm this?
I can change some windows in my packs so that I can see the subdural better from the bone.
Excellent. So if you see here, have you confirmed it? Not on
Yeah.
the same slice, but maybe, the first 3 slices or the top, middle, and right slice.
Yeah, it confirms an acute subdural.
Right. Actually, the teaching point here is, and this is how, those of you who don't do it in your clinical practice, you must do it. And in the exam also use it. There is a window, we call it subdural window, whatever you want to call it, subdural hematoma window or subdural window. This is used only in cases of acute trauma. Subdural hematoma can be chronic, so it's useless there. The basic concept is that In this case, what happened was that there was a subdural hematoma here. We missed it, and actually it was visible on this window. If you see, this is known as subdural window. I'll give you the windows shortly. And there is a subtle. So what happens is the hematoma and the bone, they become conspicuous by different densities. On the regular window, it doesn't. I have seen over last few years about 4 cases like this, which became big problems. This case, what happened? He went home because we discharged him from A&E, and he was living single and became unconscious because the hematoma increased. And 3 days down the road, the classical story, you know, the neighbors say that he is not coming out, the police barge in, and he is unconscious, brought him in, and there was a subdural. He died actually. So what are the learning points here? That this is the window. The literature tells you level 75 and window width 150 to 200. This is your choice. I usually use this level 75 and width 175. So, and you are going to otherwise miss this kind of subdural hematoma. Any hematoma here?
Yeah, again in the middle cranial fossa, I can see a right-sided fine
Right.
subdural.
And do you agree that it is better visible?
Yeah.
Okay. Any hematoma?
I think there is a hematoma along the left convexity with some mild, actually, it might be because they're so iso-intense and there's no midline shift. Could it be like a bilateral accident hematomas? But there's definitely something along the left convexity I can mildly appreciate.
Now, this with contrast, I'm not at all asking you to give contrast to make this diagnosis, but just as a teaching point here, if you see when, you know, subtle subdural hematoma, which is isodense to the parenchyma. So isodense has come in the exam many a times. Hypodense is easier, but isodense is more difficult. Key thing here is look at where is the gray white matter junction. And if you see here, the gray white matter junction is sitting here, and something is there, of course, midline shift. On the other side, you see this is the gray matter and this is the white matter. So the junction is normal. So this was only unilateral. These ones are easy, so I will just skip it, and you can see that sometimes the teaching point or the exam point is go back to the vertex. Always go to the vertex, and you in the last slice might show you subdural or acute or chronic subdural. This is just a point to remember that if you go back to the physics tells you that you know, the basic concept on a CT scan is that acute hematoma will be 56 to 76 Hounsfield unit on CT scan. More than 80 is calcification, and less than that, you know, gray matter and white matter, etc. have got various kinds of Hounsfield. But is that this depends on hemoglobin concentration, and this figure is valid for 13 grams per deciliter. And this is from literature, from rather ACR, American College of Radiology, teaching files, that they have documented a case in which the hemoglobin was 8 grams per deciliter and acute hematomas were low density. So physics tells you this can happen. How can this case present in your life? For example, there is a case in Scotland, you know, offshore rig in Scotland, and had a head injury and had other injuries, loss of blood, but the weather was not good. They are keeping the patient alive with a lot of IV fluids. Helicopter brings it to you maybe 12 hours down the road. Patient is still alive, but has lost a lot of hemoglobin. At presentation, it is only 8 grams. And when you do a CT scan, the hematoma might be low density. So that is the concept which you have to remember. And with that, the concept of subdural hygroma. So when there is a chronic subdural hematoma, if it is very ancient, very old, it might become like fluid density on a CT scan. On an MR, it can be fluid intensity, which can be CSF, just like CSF. So that can happen. This type of hygroma, usually you will see in old age group or in children. But if you see it in children, think about NAI. Now, another point is that subdural hygromas at times can be high in signal intensity on T1 weighted sequence, which will be confusing for you because of high, proteinaceous content, and the protein might be bright on T1 weighted sequence. Subdural hygromas can rarely, there is another mechanism of development of subdural hygroma, which is because of a defect in the arachnoid. This is post-traumatic. So what can happen? This is a case of day 1 and day 2. And you can see that there is a subtle subdural here. There were other findings also. But on day, you repeat the scan and you can see a hygroma. And how do you explain this? That basically there was a defect or a traumatic rent in the dura. So this is another concept of the word subdural hygroma. Very rare. I've seen a few cases in my life, but it can happen. You should understand that mechanism. Okay, candidate 7. What is this?
So it looks like patient has had previous embolization clips, and then around that there is acute hemorrhage with areas of pneumocephalus. So,
excuse me, hint A and E. Patient is very serious in coma.
so I mean, I can see a lot of pneumocephalus throughout and then there is a significant brain edema with complete effacement of the overlying sulci and some midline shift to the left and acute hemorrhage. I'm just trying to categorize the hemorrhage.
What is this? What is this? What is this? You were worried about embolization clip. There is metallic density. That's the hint.
Oh, he's got a traumatic, so like a bullet injury or something like sharp injury.
So this patient, just wanted to show you because otherwise you will get confused, as you did get confused. It's very easy. Shotgun and multiple pellets and more or less a brain dead. So sorry, here you are. So metallic densities, etc. And you can see this sharpener. This is the sort of the path of that sharpener. Okay, this case is for Viva. So what will happen, and this has happened in trauma world, it has happened in some other worlds also. The examiner has asked you tackle this case, and this is diffuse brain swelling, lot of edema. There is loss of gray-white matter differentiation. In this case, it is post-trauma. And then you can see a white cerebellum sign. If you see the cerebellum, it is normal in density. So the bottom line is that there is anterior circulation ischemia is there. And please remember that basically because of trauma. Now, here the Viva question is, why is there ischemia? This is the question for you.
So because of the increased mass effect and the hemorrhage around the middle cranial fossa, I think it has compressed the anterior circulation artery, ACAs, and that's why the anterior circulation has completely become ischemic.
So, you see, this is what we are talking about, cerebral edema and ischemia. And this is, we did cover it before also, but just to repeat because it has come in the exam. Intracranial cavity is a closed space and three things happen there. One is blood is within the vessels. Then is the CSF, which is in the ventricles and subarachnoid space. And then is the brain tissue. So they have to be in equilibrium. If one thing increases, then other has to decrease. Now, if there is edema of the brain, then what will happen? CSF, of course, cannot be compressed because it is a liquid. We know liquids cannot be compressed. But what will happen? The vessels will become compressed. Initially veins, then the arteries. And that is why there is ischemia. This concept is asked in the exam. And this is also, secondary effects, cerebral edema and ischemia. And so white cerebellum sign has also been asked. And in a brain dead type of a case, we have already covered it, the pseudo subarachnoid sign that has also come in the exam. Okay, now this patient is trauma, and patient has got Glasgow coma about 9.
Now, so there is multiple petechiae of hemorrhages involving predominantly the white matter in bilateral frontal regions, and then just at the vortex as well. With these multiple foci, I'll be concerned and worried about a underlying diffuse axonal injury. I don't see any midline shift. I don't see any.
Excellent. So diffuse axonal injury is important for the exam. And in diffuse, please remember it is one of the primary brain injuries. You remember this chart. Contusion, diffuse axonal injury. These are the only primary internal injuries. In diffuse axonal injuries, the eye see what the mind knows. What will happen? This is a sharing injury where there are, what is the location? The location is gray-white matter junction. Then there is internal capsule, then corpus callosum, and midbrain. These are the top 4, but there are others which have been described in literature. Having said that, only 50% of diffuse axonal injuries will have hemorrhage. And if they have got small petechial hemorrhage, you will pick them up on a CT scan. Otherwise, you will not pick them up. Whenever there is discrepancy between the CT scan findings and clinical, for example, if a patient has got low Glasgow coma scale and the CT is good, the neurosurgeons will actually just label it diffuse axonal injury because pathologically speaking, this is what has happened, but radiologically speaking, it cannot be picked up. MR is better than CT. Nobody does an MR acutely, but after a few days, if the patient is not recovering, they will do MR. Even on a flare type of sequence or a T2 weighted sequence, you can see high signal, where on a CT you might not pick up. But the king sequence, exam sequence, is a T2 star or a susceptibility weighted image. You have to ask, and the Viva will go in that direction. So this is gray, white. Matter junction, gray, white was normal, but on a flare sequence, you can see some high signal. But the king sequence, as I told you, is a T2 weighted or a SWI sequence, which will show these micro hemorrhages. So micro hemorrhages on MR from your book. This is a diffuse axonal injury, which is involving the corpus callosum. If you see here, corpus callosum. And this is a type of a Viva case, but I don't have time to show you in a Viva format right now. Another case of diffuse axonal injury, candidate 7. Anatomy wise, where is this injury? This injury.
So splenium of the corpus callosum.
Excellent. And this one is somewhere, next to the internal capsule, maybe the thalamus or internal capsule, but literature will tell you internal capsule. This one is maybe going into the thalamus also. This is also gray-white matter junction, gray-white matter junction. Another one in which all of these are diffuse axonal injuries, and this one is in the midbrain. So this is a case in which CT scan was normal. The patient is more or less, gone actually, Glasgow coma 5. Do you see any diffuse axonal injuries?
Yes, actually, in the bottom, I think there is focus in the midbrain and also around in the internal capsule on the right.
Right. I have not given you SWI sequences for these levels, but the teaching point here is that this was a diffuse axonal injury, and this is in the thalamus, which is this one. Actually, actually in diffuse axonal injuries can also show restricted diffusion. And this is then in the splenium, this is up in the gray white matter junction in the midbrain also. So just wanted to tell you that they can also show restricted diffusion. But having said that, SWI is the main thing you have to remember. I'll skip this case because of time factor, but it becomes very interesting. There is an extradural hematoma, and there is, diffuse axonal injury. But interestingly, this patient has an arachnoid cyst, which was present there, before. So it becomes an interesting BIWA scenario. What is it? How can you explain this? All those things. But I'll skip it because of time. Okay, I think last few things we will, I think maybe take another 10 minutes, but let's finish it. So this is a case in which there is acute over chronic subdural hematoma, which is causing subfalcine herniation and transtentorial herniation. I want you to describe the findings to me, and I'm going to give you marks for your description.
So there is a large left subdural collection along the convexity with midline shift to the right. There is a subfalcine and transtentorial herniation with effacement of the suprasellar cistern and the quadrigeminal and ambient cistern. There is associated evolving hydrocephalus with ballooning of the temporal horns. And I think there is a small amount of hemorrhage present in the perimesencephalic cistern as well on the first slide in the middle cranial fossa.
Okay, I'll take over. Now, the point is that you have to have a clear-cut idea about, you see, subfalcine herniation. Now, what happens is, in subfalcine herniation, so this is the lesion here, and this is the corpus callosum, this is the cingulate gyrus. This is the fox, so the cingulate gyrus, it goes to the contralateral side. Transtentorial herniation, of course, what happens is that this is the uncus, and uncus goes through the hiatus, and then displaces the midbrain to the other side. Anatomy-wise, the key features are that when there will be subfalcine herniation, what will happen? The foramen of Monro is going to be compressed. So ipsilateral lateral ventricle will be compressed and the contralateral will be dilated. Go back to your case. Now, this is subfalcine herniation. This is, so the ipsilateral lateral ventricle is compressed. Contralateral is going to be dilated. And you will always see this, temporal horn, which is dilated. So you will say that there is acute or chronic subdural hematoma with midline shift to the contralateral side. There is effacement of the lateral ventricle on the ipsilateral side and dilatation of the contralateral lateral ventricle, particularly the temporal lobe. This description tells the examiner that you are talking about subfalcine herniation, and then you are going to conclude, and these findings is in keeping with subfalcine herniation. So as far as transtentorial herniation, what is going to happen? Now, this is the uncus. When it projects inside, there will be effacement of the suprasellar cistern. Quadrigeminal cistern, you will only, ambient cistern, you will only see if there is an atrophic brain. Otherwise, you can infer that this is it. And there will be displacement of the midbrain to the contralateral side, or it will be distorted. And the ipsilateral CP angle cistern will be dilated as compared to the contralateral side. Go back to your case. Now, if you see here, look at the level of the midbrain, and you can infer that this is the midbrain. It is all, distorted. So this is the uncus, or the temporal lobe. Where is the suprasellar cistern? Suprasellar cistern is effaced. So I want you to tell me this, that the suprasellar cistern is effaced. There is a distortion of the midbrain which is displaced to the contralateral side. Look here. This is the CP angle cistern, and this CP angle cistern is dilated as compared to the contralateral side. So these are how you are going to describe transtentorial herniation. Another vital point is that with subfalcine herniation, at times there can be ACA infarct. It's rare, but it can happen. Anatomy tells you this is the anterior cerebral artery. You can see that when this will, go to the other side, there can be ACA infarct. On the other hand, there can be PCA infarct with transtentorial herniation. For this, it can be on the ipsilateral side, it can be on the contralateral side, which is common sense because it can press it here, it can press it with the tentorium, so with the dura on the other side also. So this is a case. Can you describe it now as the final? I think these are 2 or 3 cases to go, and then we'll stop.
Yeah, so there is an acute and chronic left subdural hemorrhage with associated mass effect, effacement of the ipsilateral sulci, effacement of the ipsilateral lateral ventricle, associated dilatation of the right lateral ventricle. There is also evidence of transtentorial herniation and uncal herniation with effacement of the suprasellar cistern, mild compression of the midbrain with increase in the cerebropontal widening on the ipsilateral side. So in keeping this acute and chronic left subdural with mass effect and associated subfalcine and transtentorial herniation.
Excellent. So here comes, now you are getting distinction marks for this, right? And have pertinent negatives, positives, satisfaction of search, any infarction?
Okay, so having a look at so there's right occipital infarction. So there is, because of the ankle herniation, there's evidence of PCA territory infarction and associated right.
We are just finishing, just a revision. Leptomeningeal cyst has come in the exam. It can come, and in leptomeningeal cyst, we know that it's a growing fracture, and arachnoid has got a defect. There is CSF pulsation which go through the dura, and everything goes out. And when the patient presents to you, it will be a baggy type of swelling, and there will be no sclerosis around it. Last case of the day.
So this is a 7-month-old demonstrating a left-sided subdural hemorrhage along the convexity and entering the left posterior falx. In a 7-month-old irritable and no weight, I'll be suspicious of an underlying NAI. And I will take the case forward by discussing with the safeguarding team and proceeding with the CT skeletal survey. Sorry, with the skeletal survey.
Excellent. So I'm not showing you NAI for the simple reason we have covered it in the PED section, but one case I just wanted to show you what is happening is acute over chronic subdural, which it goes all the way here. And then another finding is that if you see here, there is atrophy of this temporal lobe. This is not an arachnoid cyst. You can see there it is atrophic. And with this kind of, unifying diagnosis can be that there might have been a previous contusion, and now there is a bit of atrophy, focal atrophy. So this is NAI.